The next speaker will be Dr. Abreau from UC. Yesterday we had the invisible cancer, so now we proceed with the invisible prostate cancer, unseen but important.
Good morning. Yep. Thank you so much for the introduction. Thank you, FTS organizers and sirs for inviting me. It's a pleasure to be here talking to you. Okay. And the topic that was assigned to me was invisible prostate cancer. And not only this, it's invisible prostate cancer. It's not seen, it's unseen, but it's important still. These are my disclosures. MRI visible versus invisible prostate cancer. Hypothetically, only MRI visible prostate cancer matters. Only MRI visible prostate cancer carries clinical significance, importance, capability to harm, and so on and so forth. The management of prostate cancer, of the early prostate cancer driven by MRI visibility only, exclusively, will lead like MRI will be the predictor and the prognosticator. Gleason grade group will not matter. If there is grade group 2 or high and if it's invisible, that's fine. If there is grade group 1, but PARIS 5, then you should treat. What is the clinical and biological data behind this? Very nice manuscript by Dr. Embert and his group, really long, very well written, and worth reading. There are 3 scenarios. The first scenario is the cancer becomes visible before it's actually harmful. The second scenario is the cancer becomes visible and harmful at the same time, which is also okay. But there is a possibility that the cancer actually is already progressing, it's causing trouble, and the image is not picking up. Now, this is the scenario. This is a patient, is a male, with a negative MRI. That's it. Who does biopsy? Anybody does biopsy? There's a negative MRI. We are done. The patient has negative MRI. There's no problem. All good. Oh, no, Andre, but listen, there is no contrast enhanced. No. We are doing biparametric MRI. Oh, how about the DRE? DRE? Urologists don't do DRE anymore. How about race, ethnicity? No, this doesn't care. It doesn't matter. The only thing that matters is the MRI. But I will give you the age of the patient. We are not doing biopsies on 20-year-old people. Does it help? Anybody does biopsy on this patient now? Okay, yeah. So good. So let's keep going. MRI visibility for prostate cancer. Let's go back to basics. Very nice manuscript. To me, still the best manuscript to address this. Several post-hoc manuscripts on this matter, but negative predictive value is 75% or so. So when we combine with markers, then we include PSA density, so on and so forth. Then we have increased the negative predictive value. We can avoid biopsy. Better way to do. I like this very much. Very simple, easy, and a good way to go. However, if you want to go deeper, then you can assess age. You can assess race, ethnicity. Remember, not everybody in the world is Caucasian. There are African Americans, Latinos, Asians, so on and so forth. So this is also important. Going back to the case, PSA 6.3, and there were no nodules, PSA density 0.17. Anybody does biopsy now? Okay, 3 or so, good.
There's no contraindication with end-stage renal disease anymore with gadolinium.
That's correct. That's correct. This not anymore, but that time was, and exactly that's why I left it there, to provoke this. I agree. Now, I did the biopsy. The biopsy showed Gleason 7, and I did prostatectomy on this patient. And the prostatectomy showed PT3 with seminal vesicle invasion. 20% of the cancer of the prostate was all cancer. Does it matter? If not, then I don't know what to tell you. Now, you can say, no, Andre, you're just picking cherries. You just select that case. No, this is USC data, 570 patients underwent MRI and biopsy, all by me, and prostatectomy at USC. And you see there that 25% of patients with negative MRI have adverse pathology, grade group 4 or higher, PT3 or lymph node invasion, 25% of them. And it's similar to Gleason, to PARIS 3. Now, is PARIS 3 visible or invisible? Because several people, for conveniency, when they are doing the studies, they see the results and they consider parades 3 invisible. Well, you see or you don't see, it's parades 3 or not. Now, prostatectomy outcomes. There is, I don't know why this thing shift, but there is this manuscript that showing that there is some correlation with parades in prostatectomy outcomes, although data was very limited. Very nice manuscript, 1,500 patients, showing beautiful curves of survival and everything according to parades. Excellent. So let's check on this manuscript. These MRIs were done in 2000. 2000. This is completely different MRI that we do currently. And certainly, if we go ahead and we re-stratify, that will be a lot of shift. Let's keep going, genomics. And here's the main thing. If genomics correlate with imaging, then we are done. Now, several manuscripts, I checked many of them. I put only these 5 there. The largest series of all these manuscripts that I could find is this one with 64 patients. All others, 12 patients, 14 patients, 20 patients, 24 patients, retrospective, single series, so on and so forth. The only one with the largest one, 64, no correlation with Decipher or all these genomics with parades. Another series now, 72 patients on prostatectomy. Again, they checked on the index lesion versus no index lesion, and you see that several patients with no-index lesion having high Decipher score, and several patients with the index lesion with low Decipher score. This is all over the places. This is a very nice manuscript, 78 patients from Miami. Prospective, very nicely done, properly in everything, comparing parades with Decipher. Look at the results. There is no difference. Decipher versus parades on index lesion versus templated biopsy, no difference. And if you look to parades 5 only, highlighted there in blue, you see that the Decipher is all over. Parades 5 with very low Decipher, parades 5 with very high Decipher, you can't trust this thing. Actually, this is a negative trial, and this is the conclusion, and the authors reported this. It's very good that they reported negative outcomes. So caution, retrospective study, small sample size, based on biopsy, lack of standardization, there is no definition of parades, MRIs were reviewed, lack of diversity, so on and so forth. MRI visibility versus PSMA. Now, cancer is invisible on MRI. How about PSMA? Is PSMA important? These patients you're showing right there. MRI negative and PSMA showing cancer. And similar thing. In PSMA by itself, everybody knows now that PSMA carries the prognostic value in itself. So are these cancers negligible? MRI visibility paralysis limitation. This is probably the main issue. The bottleneck of this is the limitation of the MRI, by far. If we don't address this, this field has to go very careful. Quality and reproducibility of MRI are very limited and something to be addressed. Radiology limitations, burnout, workload, exhaustion, you name it. Search satisfaction. Search satisfaction means when the radiologists find a big lesion, they may or may not look for other lesions. That's what means search satisfaction. This is human being. Maybe AI will address this. Dr. Kanek will talk about this tomorrow. And not only this, best radiologists in the world. Agreement between them, 50%. Lovely. Go ahead and get your negative MRI and you are done. Invisible prostate cancers matter. Invisible prostate cancers are important. What is the percent? I don't know. I would love to know. If somebody knows the answer, please tell me. But invisible prostate cancer matter. MRI visibility versus parades. And this is important. It's not visibility only. It's parades. Parades is not see or non see. Parades, there is a volume. Parades, there is a size. Parades, there is conspicuity, density, so on and so forth. Definition, we need to define what is visible or invisible. What imaging? Is MRI, PSMA, ultrasound, micro-ultrasound, multiparametric ultrasound? Markers. PSA density is one of the stronger prognosticators that exists, and then we completely ignore. Negative MRI, forget about PSA, we are good. And there are patients' factors, age, race, ethnicity, family history, so on and so forth, and all these limitations that I listed. Thank you.